All right, what's going on, everybody? So my talk today is going to be about our peripheral vasopressors. So obviously, vasopressors, they're something that we give pretty often, pretty much daily in the ED, to help with hemodynamic support in the critically ill. The current dogma, really, from the ER standpoint, especially where we work, is that they only be given through the central line. The whole point of this is obviously just to try to avoid some of the complications that could happen as a byproduct of the properties of these medications. Tissue necrosis, limb ischemia, and stuff like that. But on the same token, that's not to say that a central line isn't going to cause any sort of problems either. We could put the patient susceptible to bacteremia, pneumothorax. We could puncture the artery. So there are times where the current dogma that we hold in that vasopressors only going through the central line could really be putting patients at risk. Studies have shown that delay in giving the vasopressors for every hour, there's actually like a pretty big mortality increase. So the question I'm going to try to answer today is it okay for us to be giving this stuff through the peripheral line, or should we just be sticking to the central lines?
Or let them die.
Or let them die, but that's...
because in this current code situation where they're going down...
there's obviously always IO, but this talk is more focused on the IVs rather than the IOs. So the first study that's largely been cited comes out of France by this Dr. Ricard. They were comparing central versus peripheral catheters for IV access within the ICU. So it was a 2013 trial. They included 263 people in the trial. 128 were randomized to the IV side and 135 to the central side. For the peripheral IVs, primarily, they used 18 and 20s, as normal length. They checked on these IVs every day up until just discharge or up to 28 days. And for the peripheral IV side, they pretty much changed out the IV every 72 hours according to CDC recommendations so that they don't get infected. And so the two major categories that they looked at was grouped as major versus minor complications. For the minor complications, they include stuff like small hematomas, stuff like cellulitis, thrombophlebitis, to kind of compare the two. Obviously, as I've shown here, there was really no significant difference between the two groups. For the major complication group, they did find a significant difference with peripheral IVs having more complications. Part of the problem with this major complication group was that it was a very broad category. It kind of included all the things that I listed here on this table. They kind of categorized it into three categories: mechanical, infectious, and thrombotic. But they grouped stuff like pneumothorax, arterial punctures, hematomas in the same group as having difficulties putting in the IV itself. So the significant difference that they found was actually primarily largely due to having trouble getting the IV in. 56 of the 133 major complications were largely due to just being unable to put in the IV. So there was that aspect of it. But otherwise, from the minor standpoint, like I mentioned before, there really wasn't all that much difference, and almost half of the IV group only stayed within the IV group, and for the other half of the IV group that needed conversion to central lines, half of them needed it because of increasing a vasopressor requirement, and the other half was just because they just couldn't get the thing in. So part of the limitations of this study was the fact that the categories were just really broad for the outcomes. Very few specifics included in the study itself, where the IV was placed, exactly what kind of vasopressor were used, or the demographics of the patient, why they were getting it, and they didn't mention at all whether ultrasound was used at all for the central lines or for the IV lines at all. Though I'm guessing that they probably didn't. So for the second study,
one comment on that study.
Yeah.
When they did have extravasation, it actually lead to a terrible bad side.
So
There was extravasation.
Yeah, so there was extravasation. So those things were grouped under the, I suppose, the infectious / thrombotic category. So if you look on the chart, like the middle half, there was erythema, phlebitis, catheter infection. So they were included into that group of it.
I'm just saying that when there were extravasation events, they weren't
You were correct. Yeah.
None of the new studies have any major comorbidities from using peripheral vasopressors. None of the studies from 2013 on have negative outcomes, whether it's gangrene, sepsis, loss.
Yeah. And so those are the other studies I said later on.
Sorry.
Yeah, no worries. Yeah. So the second one is one from Canada by Dr. Lumbani. Basically, they did a systematic review from like Medline, Cochrane, just like the whole PubMed. They pulled 85 articles, finding 318 adverse events. 2/3 of those showed local tissue injury, whereas a third of them showed extravasation. Of the 204, I think like 180 of them were related to skin necrosis by itself. And for the extravasation group, about 75% of them didn't have any sort of local tissue injury. So as it's broken down, about like 75% of it came from case reports and case studies prior to 1980. Primarily, the vasopressors that were used found within these studies was primarily norepi, followed by dopamine, which account for like, I guess in total, maybe like 90%. As far as placement of where these IVs were, 85% of them, both in the local tissue injury side as well as the extravasation side, were all distal to the AC or the popliteal fossa. Although it is worth mentioning that on the extravasation side, about half the cases, they didn't really mention exactly where the IVs were. So it's kind of tough to say exactly, how accurate this data may be. And as far as the duration of the infusion, primarily the duration was primarily more than 6 hours for most of the events, for about like 98% of the events in which there was actual local tissue injury. So as far as the limitations of this study, part of the problem was that they were largely pulled from case reports and case series. So you can't really get an assessment of whether it was, what kind of proportion of IVs placed versus, events actually happening. So we can't really say that. It's an absolute number really rather than a proportion. Secondly, there was also a reporting bias in the sense that, it only shows up if they reported it. So it could very well be underreported. And lastly, there's also inconsistency in the reporting itself. So a lot of the data wasn't really very specific. They just, like I mentioned before, in this extravasation group, half of the patients didn't really say where exactly the IV was, and 66 of the 200 in the duration chart, they didn't really mention how long the IV in the infusion was in place for. So that's that study. This one out of LIJ by Paul Mayo also looked at the same thing. It was a single-arm study. There was an N of 783, and amongst the 783, only 2% had really any sort of extravasation event. The duration of the infusions amongst these 700 or so patients, there was a mean value of 49 hours, plus minus 22. So these people were getting these presses for like a really, really long time. That being said, it was also a really rigorous protocol in the ICU. So once the IV was placed, they had to meet this whole set of criteria. The vein had to be bigger than 4 millimeters, confirmed via ultrasound. They had to see that it was in the vein through ultrasound. They were only able to use the upper extremities, and it couldn't be in the AC, the wrist, or the hand. Furthermore, they used only long 18 or 20 gauge catheters only, and the nursing staff they were checking these lines every 2 hours. And lastly, there had to be blood return from the IV prior to any sort of pressor use. So I don't know if getting all this together in the ER is really all that feasible as well at all, but that's what they did in this study. For the 19 patients that did have extravasation, they did institute a rescue therapy. So basically what they did was they would pull the line, they would kind of outline where it was, and they would inject phentolamine around the area and put nitro paste over the area. And of all the 19 patients, none of them had any sort of events where there was any sort of local tissue injury, so they all did okay. Part of the limitation of this study was that there's really no control group. It was single center, and they were all obviously very skilled, multidisciplinary staff. with a really regimented protocol. So they were only really focused on safety. They didn't really mention you couldn't really say whether this had any sort of outcome on that you can have any sort of influence on patient outcome. So that was the study out of LIJ. And lastly, the study out of Lebanon looked at the same thing as well. Just from this year, there's an N of 55. They looked at the major minor complications, major being stuff like tissue ischemia, limb ischemia, or tissue necrosis and limb ischemia, and minors being cellulitis, phlebitis, and extravasation. Amongst this group, they also only used 18 and 20 gauge catheters, normal length, and they found that there were only really 3 complications in this group itself. Primarily, they used norepinephrine, and mostly for sepsis. These IVs were primarily placed in the AC and the hand, and really the duration of this infusion lasts for a really long time as well. Norepi having a mean time value of 13 hours, and dopamine being upwards of 53. Of the 3 patients, they all did well. They all were on norepi, and these were the complications from the extravasation. If I can recall correctly, these presses were used for upwards of like 20 to 40 hours for each 3 of these. There wasn't any sort of aggressive treatment, and they did okay. There was no tissue necrosis of any sort. So that was this study. Part of the limitations of this study was that it was really small sample size, obviously. They essentially only really studied norepinephrine, and there's no comparison group. So I guess taken all together, what can we really say about pressors in the periphery? I think for a really, really definitive answer, whether each pressor is okay to go through the periphery, obviously more trials need to be done where they're larger and more specific. But at this point, from the data that we do have, I think that we can say that's probably safe, especially if we use norepi and dopamine. If it's proximal, if you use a big gauge IV like 18 or 20, and if it's run for, I suppose, less than 6 hours, and if there's any sort of concern for extravasation, then we can institute the policy that they did at LIJ using phentolamine and nitroglycerin.